without further ado, I'm turn it over to Jesse, Rue and Mike Schwab, Pharmacy Association / North Dakota Pharmacy Service Corp, to provide some information on some updates that have just been a long time coming and finally here. So just to make pharmacists aware of the state of the opportunity. So, gentlemen, who am I handing the microphone to first?
I'll take it.
Okay.
Thanks, Liz. Thanks, everybody. For those of you that don't know me, I know many in the room, but Mike Schwab with the Pharmacists Association and Pharmacy Service Corporation. I'm really just here for some good old moral support for Jesse. This is his presentation. He does a really good job. He's provided a couple times. We'll get into the health information exchange a little bit, the CPA models that we're currently rolling out at a number of pharmacies. But Tiffany, obviously from the department, is here to talk about a little bit more about the HIE when we get into it and what that might look like in the state of North Dakota. But with that, I'll just turn it over to Jesse. And again, I'll engage more in the discussion and questions when they come up. Thanks.
All right. Thanks, everybody. Pleasure to be here. I'm Jesse Rue. I do a couple of things. Work with the NDPSC, the Pharmacy Service Corps, and then I also work at the hospital in Rugby, the Heart of America Medical Center. So a couple things going on there, but with that biography, I'm nobody that's particularly important, nobody that's particularly interesting, and I'm not even well dressed anymore, which I used to be once at a time in my life, but that is well in the past. So just got a few things we're going to go and talk about here today. It's really more of an update on just a few things that we have project-wise going on in North Dakota out of our office in collaboration with some different groups. So very, very informal. At the end, I'm not going to really even ask for questions. I'll just say let's ask for a little discussion if anybody wants to talk about anything near and dear to you or just some of the things we talk about today. So the first thing we're talking about is, I think Mike alluded to, a collaborative practice project that we've had ongoing. We're building for several years, which seems like a long time, and it frankly is, because a lot of things take longer than you think they will. No battle plan ever really survived that first contact with the enemy, is what Napoleon said, or so they said. So Element Health, we just saw that we needed some kind of an internal type of name for the project. So I just decided that's what we're going to call it. And so we did. And what it is it's a way that we're trying to provide community pharmacies with more access to building out some CPA service lines in North Dakota. Because we felt that that's something that is definitely necessary. And for us to go and make some real changes or expansions of what we're doing, we needed a mechanism to do that. And so Element, you could just consider, is the mechanism. So what is that mechanism? I should probably lead with that. We try to offer an easy way to expand collaborative practices in North Dakota, really with 3 ways. So the first part is through providing a fairly turnkey standardized set of CPAs plus staff protocols. So the CPA is really the legal agreement with a provider, and the staff protocol is, if you handed it to a staff member, they'd be able to follow step by step how we're going to actually execute doing a strep test to treat, for example. The second part, which I think is the innovation or the hardest part, is access to medical staff to discuss CPAs and get those signed. Why that's been important. For us, for me personally, I've been to some degree off and on trying to get CPA expansion since at least 2017, 2018. And we are at the end of 2024. And over again, the hardest part is not that there's not a need for it in pharmacies. It's not even that we don't have people in the pharmacy or in the local clinics, health systems who are willing or find value in it. But it's actually avoiding the need to go and repeat this community by community one-offs over and over again through 10, 20, 30, 40, 50 communities. So what we've done is pursuant to some law changes, we've went and we've formed a relationship with some medical staff where we can go and get places in contact with them with the standard set of CPAs so that we can actually go and get those deployed community to community in a very rapid fashion. So that's the second part. The third part, there is an optional bit, which we'll get to in just a few minutes, where there's some software where people can go and operationalize some of those, where record keeping and awesome things like patient screening and the actual operational bits of those CPAs in the day-to-day, which again, very optional, but we'll give you a little flavor of that shortly. So this is our first set of 10 CPAs. I guess it's kind of, what is it? PowerPoint malpractice to try and read everything right off the slide, because you can sit there in the audience and just look at those bullet points yourself. But just to highlight, we have some ones I think are pretty commonly used and interesting. You know, people, they say, well, at the community pharmacy, the top 2 are always strep and flu. So you definitely see those. But we also have some UTI and some birth control types of things, which I think are good and needed in a lot of communities, you know, regardless of how the OTC birth control type of thing ends up playing out. So we have, I think, a nice initial set, and we do hope to grow that as time goes. But we do have a little cursor, whatever. We are launched and deploying as of this month. So we have our first about 6 stores who are trained on this. Probably have another 4 trained next week. And so we do have a list of, 20, 25-ish that have had a lot of interest, and we hope to go and make those deployments. So we're really hopeful by the end of the year that we're going to have multiplied what CPAs and some of these clinical services across the state compared to what status quo has been at your independent community pharmacies, far away exceeding what we have today. Which, again, that's somewhat ambitious, but also not ambitious. So I guess you decide how you want to categorize that, but we find that it's important for us to try and do that. Again, I guess I skipped over and I kind of already talked about the contents of this slide. So shame on me for not practicing more, right? But the 2 parts, the CPA and then staff protocol. Not a great visual here on the screen, but just imagine 2 different Word documents. Wow, you really painted a picture with that in your mind, right? Got the CPA on the left, the formats are always the same, so hopefully that's fairly easy for staff to go and understand. All right, so now I have to go and share a little video type thing that I have here. And well, thanks for your patience, appreciate it. About a 2-minute video here, and we're just going to show you a little bit about some of the data collection options that there are, because visuals can be nice. So again, for any of the CPA screenings, you do have some sort of a screening process for eligibility, and we're going to show 3 different options for the, again, optional free software if you choose to use that at your store. Questionnaire 1 is really manual entry by staff. So if you had a paper form and you wanted to go and put that data into the system, very simple to do that. So we're in the system. You can go and enter, grab a patient, navigate over to their patient profile. And then we can go down to the questionnaire bit, manual entry by staff, and continue. You select whichever sort of questionnaire you wanted, and it comes up identical to what the patient would see if they're doing this on their phone. So the step screening is really this: age, pregnancy, symptoms, and we can also go and add an actual signature capture for this. So this feature really does get useful, or can be used for consent forms of any type if you have vaccines, etc., because we are actually capturing signatures here for you. Got that? Text to the patient phone. So if you want, you can just go and send it directly via SMS. Send the patient via SMS, click continue, pick your questionnaire type, continue. It's always kind of weird doing this because, I obviously recorded things on my phone and my computer screen making this demo. So it's kind of like a little trip down memory lane for me. It's my dog in the top right. His name's Buxton. Got the notification here. Jesse Rue's requesting that Jesse Rue fills out a screening. There is a birth date check. So hopefully I did that right. I did. And I am 38. Wow. I used to not be. We'll go through that. I can go and sign, put the signature capture there, or write like that. Submit the answers. And at the risk of really boring you guys, we'll do it one more time. This time, though, we're going to actually go and generate something, a QR code, after we look at some results. So the results for somebody, every time you take a questionnaire, you will actually see those results come in one by one after the other. Very simple. It's just a table. Not like anybody's not seen a flow sheet or a table before. But you can see for something that's not really acute, if you have something like some SDOH type of screenings or chronic disease monitoring, having a flow sheet like that will have some additional value. Less so for your strep and flu, but maybe you like it. Now, the last way we do this, we have the ability, like you may have had in some of the medical clinics you've gone to, where somebody hands you a tablet and you can queue up different patient forms. Then you hand it back to the person at the desk. So we have the opportunity here to go and launch a unique QR code by session. We go and take that. You can scan that on your phone or your pharmacy tablet, hand that to the patient, and they'll be able to go and do that right on the tablet there. So that's my phone doing it. This is a test system, so I didn't build it out, but you have the ability to go and categorize everything that you want if you're doing multiple types of service lines at your pharmacy or different screenings, or if you have just some vaccine type of consents, et cetera, you can go and do that. If you select multiples, they will go and do one after the other. So we've got the element category, the strep CPA. For the third time, you see we go and do that. Just the same way. So I really just want to kind of show you that, and that is the video there. Now to swap back to the slides, now we're really going to have a fun time doing that. Let's see if that works right. It did. Oh, good. That's wonderful. Love it. So what you saw there is what we end up calling Starfield. So that is a bit of software that we have, and I think it works some interesting ways. But it can assist the CPA project in a couple of different ways. So documentation after visit summaries, consent, intake screening, pharmacy patient list upload, and some reporting. One more time, that little logo. I think it's decent. Do you like it? Do you like that? Yeah, kind of. Anybody hate it? No? Too polite. Pharmacy usually is pretty polite about that. So let's get to the Starfield portion, back to the software. So what Starfield is, since this is not a household name like Nike by any means, and it's never going to be. But if you thought of the software as a pharmacy specific or pharmacy type focused EMR plus community care coordination program, I think you're fairly close to mark to what we hope that it is and will be. With key capabilities, multi-location concept for care teams, meaning if you have a patient that receives care at several different areas, you will have the ability for people, care team members at different locations to see and share and collaborate on that patient with the proper consents, of course. We can close the loop with some task assignment and completion. You just saw the mobile questionnaires, useful for a lot of things. We have consents, terms of services, provider privileging, restricting some access and capabilities, Dexcom CGM integration. Some of the exciting parts, I think, is we do have the ADT for clinic, ER, and hospital in the state of North Dakota through NDIS, actually, excuse me, NDHIN, not NDIS, get into that. Labs from the NDHIN, these actually, there are some foibles to work out, but we're really excited that we're actually able to go and make that a reality because it took years to get to that point. Immunization forecast for info and the IIS, notes, billing, bulk upload of patients, questionnaires, Medicaid data. So it's never really a terribly effective way to spend your time to go and look at software, but it's also not really, it's very, very abstract if you don't at least have some kind of a brief visual. So here are a couple of screen caps for actually a new release. We're releasing quite a bit of product here in about a month. So the main task area is here. You can end up, well, maybe you can't see. I can see it well on my screen. Is that kind of washed out? Maybe on the sides a little better, but I guess with how hard it is to see, it's probably just me talking and you just kind of imagine a little bit. So we can go and generate tasks, multi-step tasks. We can go and assign those to different people, unassign them, attach resources, instructions. We can schedule them, add recurrence, etc. And really quite a bit of flexibility for that. We can also go and create quite a bit with programs or order sets, depending on if you're more community focused or perhaps more health system type of focus. When you get into the patient, we do have a lot of different tabs with the information we have. We can see the tasks down below. You can see some assigned programs. We'll talk a little bit more about that, but if you just imagine your programs as a set of orders or tasks or actions, that's really what it is. And that allows us to go and create and deploy a lot of standard types of care to a lot of different patient types, from anything from tobacco to who might need some help in the community. Also Medicaid type of programs that we have. So we do like that. You can see some of the questionnaires, the CGM, medications, etc. And just a brief image showing that we do have some live data that comes in from the NDHIN. And we have limited data points, but that's easy to expand. With NDIAS, we have a forecaster, which really nice to have. And we've added some nice features based on feedback where we can go and apply patient lists, search and filter based on tags, defer, enter in the data for the vaccine entry, etc. For those who are heavy CGM type of users, I know there's probably a few in the audience. I see the former Ms. Wendell there. I know that everybody does. They do quite a bit with CGM. We have that information. And now I will talk a little bit about the programs that I alluded to a little bit earlier. So within Starfield, the basic unit of work is the action. It's a task. I honestly maybe made a mistake when I started calling them actions because I chose it because action just found it a little less worky than task, which is good or bad, but sometimes I have to explain myself. So is it actually good or bad? I don't know, but that's what we have. So we can create the actions. We can also create multi-step actions. So if you have something that needs multi-steps to it to actually complete it, like you need to do a welcome to your pharmacy or system, etc., you can go and create sub-steps that have to be satisfied before that unit of work is actually done. And a collection of actions would be called a program. Again, there's many ways to go and say that, but if you think of a program as like an order set where you have different things that have to go and happen, or a protocol, that would be accurate as well. But the programs where things get exciting for us personally. We find that they're pretty powerful because they are customizable and they do a few different features like automations, quick launches. So if we have something where we want to go and send out like the questionnaires that we saw a few minutes ago on an automated basis, we can go and do that. So if you have somebody who you want to go and monitor for, say after discharge, you want to go and establish what their daily weights are for CHF discharge, and you're going to send that out automatically every day for a week or whatever cadence you feel, you can go and do that. I think anybody can think about how would that work from a tobacco perspective. For example, if you start somebody on tobacco and cessation therapy, we do want you to have some pretty specific follow-up. So we can go and select actions to remind your staff, but we can also go and create these sorts of things that go to them automatically as well as you do before. We'll talk about some of those. Quick launch allows us to go and say, if we have a documentation or billing function that is required, we can go and do that and set the proper template to actually launch. There's no errors for your staff to remember what is correct for that. So that isn't anything that's new. I mean, that concept isn't new. I saw a few eyes kind of glaze over because, well, that's simple, it's common, it makes sense. A lot of people in pharmacy or pharmacy systems don't necessarily do that or don't do that very well. But I just really want you to kind of, at least until I'm out the door, just imagine building standardized programs for your patient base, depending on what their situation is, what the payer is, what kind of care you want to deliver. And if you can do that and easily deploy that over and over again to your roster of patients, what kind of capabilities does that actually give you? I think it's very interesting, especially when they start thinking about populations of people, particularly looking at some of the underserved or Medicaid type of patients with the various disease states that they suffer from. So for me, that's where it really gets exciting, and I guess I like that a lot. So a few examples I know that there was I've heard a really, really wonderful keynote speaker from back in the back corner of the room earlier. Looking forward to talking a little bit about that more, but I do believe that the day of CHWs in North Dakota is certainly coming. And in my opinion, some of what that looks like for us in North Dakota pharmacy space, we look at completing some of the screenings with a variety of assessment tools. We looked at that a minute ago, obtain the consent, closed loop referrals, interdisciplinary care teams, coordinate with community resources, share data securely, and utilize the ADT information to engage when those patients are at their most vulnerable. And it's been a long-term belief of me and there are probably many people in this room today that in North Dakota, one of the most reasonable, most rational places to have a home for each patient across the state, in large part, is at their community pharmacy, because we have that community pharmacy coverage across most communities in the state. And I think honestly, outside of communities, probably the only, I think, business type that's probably more ubiquitous across our communities in North Dakota are gas stations. And I think it's really unlikely that gas stations are ever going to want to get into the care coordination business. Could be wrong, but I think it's really unlikely. So I think that pharmacy has enormous potential to go and get into this line of work in a lot of different ways. Not that it's easy, but we do have some of the capabilities, and that's why I kind of like to talk about capabilities and building programs around them. So if we talk about SDOH and CHWs, well, if you want a full SDOH screening once a year, no problem, use the questionnaire feature. 3 different ways to do that. If you want continuous and comprehensive monitoring that's ongoing, you can do that. Send a quarterly housing screening, send a heating screening only during the cold months. Maybe you want to do some more targeted mental health outreach in the holiday season, which is more of a struggle for people. You certainly have that ability. We can build programs and we can set automations to make that work. The EDT information, and I'm sorry, I should have said what that is. That's admission, discharge, and transfer. So when you're in a health system, you're at the clinic or the ER or the hospital, when you get admitted to any of those facilities, there's an EDT transaction that brings bits of information for you, what you're there for, what happened. And then when you're discharged, that also gets sent. So when you have the ability to consume those bits of information, we can get notifications and we can go and then build programs around how do we go and get people set up with what they need at that time, which for most people, if you have any chance to intervene with people who have social or health needs, it's probably around those sorts of times. Very, very important. So we do like that and think that's extremely important for us. Chronic disease examples. So CGM keeps becoming more and more important. I love CGM. I think it's one of the most natural fits for pharmacy in my career, anyway, which is graduated in 2009. So device-based monitoring is extremely important, but I just encourage people not to go to sleep on deviceless monitoring. So if you think about diseases that can at least in part be monitored by text or non-devices, CHF, hypertension, housing, COPD, depression, anxiety, there's at least half a dozen more, probably more than that, condition. But the way you can do that is, well, CHF, all of those things like CHF or asthma, COPD, you have some symptom-based data that can come back to you for intervention. CHF certainly weight-based and symptom-based. And so if we look at some of the devices monitoring capabilities, we can go and rapidly expand the patient base that pharmacy or pharmacies or pharmacists can go and monitor and intervene with. And for me, that's something that's extremely, extremely exciting. Yeah, I'm not the most excited looking guy or speaker, but the excitement's there. Yes, please.
So when you're doing device-based monitoring with CGM and you're in a community pharmacy, how then either get that information back to the provider made the decision, or do you personally at your pharmacy or other pharmacies in the state have collaborative practices where they're then allowed to make medication adjustments for that practice?
Yeah, so I think the answer is always feels like a cop-out, but it's any of the above or all of the above. So pharmacists without a CPA can't go and independently make those adjustments on those things. If you have one, you certainly could. And so I think some places will want to do that. One of the reasons I think CGM is so important is that it gives you extremely actionable information, and pharmacy may actually have access to it for decades, or as long as we've had healthcare in the country. Pharmacy often is cut out from having the information that they need to go and do that kind of work. But with CGM, that changes that. So we have the information at our fingertips, really, if the patient chooses to share that with you. And so even if you don't have a CPA in place, you have the ability to make very data-driven, black and white type of recommendations or discussions with their provider if you want to do so. And so I just think huge CGM fan for that and many other reasons. And again, I wish I had a better answer to give than, well, maybe all of the above, but it depends. I don't know if that's satisfying or not. Not quite, right?
It is.
You sure?
Platform, so I've used clinics, so for me, if you have a library across the street, my kids down with the CGM, like, bill for it, which I use for everyone, but I just want to make sure like that those in the community, they're still have an opportunity, or they're working with their providers or should do that.
Yeah, and for some folks in the audience too may not realize, but North Dakota Medicaid does allow for billing with North Dakota pharmacists for CGM data interpretation. That really is not tied to a CPA, and I think you're kind of alluding to that as well. If nothing else, having that CGM data for you, if you choose to monitor that for your group of patients, there's no downside in my opinion. And one of the reasons I say that is if you go to a lot of the clinics, CGM definitely started an endocrinology type of clinic. That's moved rapidly with insurance coverage expanding for CGM into the primary care clinics. And so if you go and ask primary care providers, many of them will say CGM is great, but a lot of them are not looking at that information very often or if ever. And so if pharmacy chooses to take that role, pharmacy has the ability, I think, to fill a very, very, very pressing gap in monitoring those patients consistently in a way that the primary care clinics probably don't have the capacity to do. Not that pharmacy is flush with capacity. I'm just saying, I think that that's a real sweet spot that pharmacy should really, really aggressively try to own. What's up, man?
2 questions. CHWs can do CPM. We're doing that. We're doing CHWs helping with it. 2, you can express value by making sure all persons with bolus insulin are on glucagon. So we use that as a quality measure to say why we're doing something different, and then change outcomes because hypoglycemia is one of the top 3 medication related causes of hospitalizations. So that's a win. And then this is probably cheap directly in replacement data velocity. I'll sleep really quick. What's the backend data infrastructure with data scanners on this? HL7.
HL7 with our HIU. Like, yeah. Mm-hmm.
NCPP is making AT data scanner.
Good. Good. Thank you. No, good comments all around, I think, on the CGM thing. CGM often listens quite a bit on comments, so appreciate that. Okay. So MTM programs, you can craft the standard actions and programs for each of your service lines, schedule actions throughout the year for your staff, elevate your chronic disease management with devices monitoring and the SDOH type of opportunities, and also encourage you to think about how text-based monitoring can really fit. In the back example, and I think other public health efforts did briefly mention it, but when you're doing something that has a medical component, but also something that's very, very behavioral, you do definitely have a need for engaging those patients regularly and probably in a way that many of us have not done before. And so, kudos to people at North Dakota Tobacco Control. Steve Neal, thank you for being here. Brody, the efforts that you in particular and others have done to try and grow the tobacco cessation skill set across the state really speaks well of you, and I think everybody else. So we're just looking at this as something that as a supportive type of tool for that work that I think has some value. So again, just to wrap up here, we'll have a little discussion. It's really important for me to try and describe that we are not trying to build something that dictates how you or anybody else does your job or provides any care to patients. We look at what we're doing as trying to build capabilities, trying to build a tool. And based on how those capabilities, we were really interested at seeing what you come up with, in essence. That's really what we want to go and support. Because there's anybody who builds tools, really, I think if they're honest with themselves, they do not have any real concept of what's out there or what's going to happen tomorrow. We really want to build the ability for you all to go and do something that's special for your patients and your profession. So that's all I got. And, I know we got not a whole lot of time before I get kicked out here, but I won't say we asked for questions, but if there's any sort of discussion, I think that people want to have, let's just discuss that as a group. And certainly, Liz or Lisa, you're very welcome to take the microphone away. But yeah, discussion-wise, is there anything that's kind of near and dear to your heart or that you found particularly interesting at any point today? I know you've been here since 10. It's up.
So just to be clear, Starfield is not live yet, or only for the pilot.
Starfield is live. We do some of the screen caps we saw. Those are, I think, some improvements that we're looking at for the end of October, probably launching. So what you see is live, it's functional, but based on some of the feedback, we do try to iterate and make that better.
So when would someone be able to, like, community pharmacy and event here? When would we be able to sign up for it? And is there going to be training on the website? You just kind of walk through it.
Yeah, just send me an email or anything like that. We can still do that. There's no cost for you to use it. So we can go and have a talk about what makes sense for you when you'd like to get trained, how much training, how little, et cetera. So it's one of those things that's not particularly difficult. And I really think that as we turn the calendar into November, I think that's going to be a much more mature and satisfying user experience for people. And
I'm curious about that, the collaborative practice agreements, just where we're at with that set of agreements, how they'll be made available. And is it be something that we'll have to pay for to participate, or how that'll be made?
yeah, so they're available now, and if you want to talk to us about it, it's just, by all means, talk about it. As far as anything else specific business-wise, I can say a few words. Otherwise, to review those, there's certainly nothing, but the costs really come with the medical staff.
Yes, I mean, we're rolling out CPAs to a number of pharmacies right now. And there is a cost to it. It's minimal. And there's a range. I'd be happy to discuss that with you, but he alluded to Starfield. At this time, Starfield, there is no cost for anybody to use it. We hope to keep it that way. We've been fortunate enough through a lot of our partners to get some really good funding to do that over the last few years. And we hope for some continued efforts, especially as we look at the HIE area and social detriments of health. And so, yes, one of his last slide, I think, said limitless. And that's really kind of what Jesse's process has been here, is trying to make this so it can apply to public health, can use it, FQHCs could use it, especially as we move down the SDOH route. So feel free to reach out anytime.
Like what I remember from the fee schedule, there was a fee for members of the Pharmacy Service Corps, because that's what fronted the cost to get this up and running, and then a fee for members that are not members.
That'd be correct. Yep.
And I don't remember the exact number, but I know the board talked about it. It was not. Yeah. You're gonna make that back and.
Yeah, the hope would be a couple patients, hopefully you get it back.
Yeah.
Or I shouldn't say couple, but a handful.
And these are more than the symptoms. These actually have a provider attached to them. So
They
you
have-
don't have to go to a local.
They have a provider attached to them. The protocols are all laid out. They've been reviewed by, physicians, medical staff, et cetera. I don't want to get into any type of deviating from what they are. I mean, we'd like to keep them the way they are because they've been reviewed and pretty consistent across all pharmacies. So. Gail.
I also mentioned that our student pilots that we're doing with NDSU School of Pharmacy, students that are out in the community doing rotations with the Department of Health Services and the School of Pharmacy and NDSU. We are having students utilize it. So if you are receiving students on their P4 rotation, there is a good possibility we would be able to have them trained in utilizing Starfield. The reason we train them up front is so that they help on for the staff in the pharmacy. The students have a little bit more familiarity, you know, students, no offense to any of the room, but have a lot more tech experience than many of them. You know, they're gonna be able to help on more than pharmacy staff. I'm not calling anybody out, right? They've been on before, I've been on too, so for these students to have those things. So again, their experience with PGM, with SMB, with self-learning blood pressure, and Starfield will be really instrumental.
And I know Jesse's really excited about CGM. I'm really excited the fact that we've got a live ADT data feed daily, which is kind of nice. So you can see discharge data right away. Gail.
Yeah, you want any names or?
Well, I mean, is it like a physician, a nurse practitioner, or is it?
Yes. One of each. Said we had. Yeah, well, one is largely engaged is in PhD.
Okay, I have a sister.
What's that?
And then.
From North.
Oh, you're kind of acting like it's a secret, so what?
No, it's not a secret. It's an NP is in rugby, and then as we go, we like to build that roster out further.
Based on location wise.
Yeah.
So just to kind of put a plug for this, and I've been really excited about this for a long time, but you know, there's other states that have like statewide programs like that. This is really, you know, besides my maybe the state, like I don't know, that blanket pharmacy to describe on any based off of anything like that. This is really going to, you know, with this EPA, because the list that you saw there is going to put North Dakota, it has right now, Dakota at the top or in that top range for what pharmacists can do, because any pharmacy can get access to the EPA. It's not acceptable to find person, you have to get it if they're available through our pharmacy service for. So any pharmacy at this point, I know you guys are rolling it out and, you know, but there is available right now. This has been in the works. What is the North Dakota Pharmacy Service? Here. Okay.
The Pharmacy Service Corporation is a subsidiary of the association, been around for a couple of decades. And really it's consists of mainly independent pharmacy owners. And it really drives a lot of what maybe they would like to see more in the community type of setting. And they help fund some of our various activities that maybe as a small association, we wouldn't have the opportunity to do sometimes. And so, so what you'll typically see is from the Pharmacy Service Corporation is they look at, okay, well, these types of efforts are beneficial to obviously the whole profession of pharmacy with the concentration more on the community side of things. And in order to get that accomplished, we all got to kind of come together and figure out how do we make this work. And so that's what a lot of our Service Corp members do in terms of belonging to the Service Corp.
Thanks, everybody.
Any other questions on before we move on?
Yeah, so when it builds, like you said, it's part of the health information network, will patient things be in there already, or do you have to like build your population into it?
Yeah, so you have to load your patients into the connection. So if HIV then does a matching process, and if they are matchable, then you have the data come. If there's any sort of rejection or mismatch, it does not occur, and that's really regulated completely by the beginning. So the rules they set, we definitely have to adhere to. That's how we build that information. But we don't have a specific, because we are going out to recreate every screen of people in the end. We don't have direct query to go and just search for patients. We are related to the login, so if you want to. But I think it has to be made with the criteria in sets, and if that's successful, then that data that we have will be available for you. You don't have the names.
So work with your pharmacy software?
So that's something that's, on our roadmap, we both have 6 weeks, so we have a direct integration into website, for example, today. Difficulties with that are not every pharmacy uses one system, so we have 5 integrations. Integration can go really nicely, but I think a lot of folks tell you it's very, very easy to integrate into that. It takes quite a bit of time to try to explore and grow those. So for us, I think our roadmap is like to find one of those unfortunately, we don't have a community situation. Most market share we have is about 10% pharmacies in one system. So that makes it difficult. So we probably 5 or 6 patients to get communities and pharmacies to that automatically.
Other questions on Starfield or the CPAs that are available now in pharmacies? And if there's questions, or let's say the pharmacy in here that's interested in implementing it, they just contact you, and or you can contact the CAP center, we can put you in contact with that team, so.
Yes, I'm on.
Yeah. So putting in, and I think this really ties well a lot with what was presented here, also with even what you mentioned earlier about health equity. We've been doing some mapping in the tax center and your teams. You probably, this isn't new to you, there's a lot of counties in North Dakota where pharmacy is the only healthcare provider within a driving distance, right? Within a reasonable driving distance. So access to healthcare, like for instance, access to an albuterol inhaler or access to strep or influenza screening and testing to test and treat is really critical. So as well as in not in our rural areas, but also some of our metropolitan areas too, where transportation seems to be a challenge. So being aware of that as well. Yeah. Yeah. We make one more call. Yep. Like another play.
I just want, I'm Jeff Johnson from the association as well, and we just wanted to plug in that we also have diabetes prevention cohorts that we're running. And I'll have a new one starting this fall, and we typically utilize students to do the process. You have the students working for you. You can reach out to me or hotline, usually send emails, all those presentations explaining them how to sign up their patients in the program, or at least know where to find them. So we do have those diabetes prevention cohorts available. At any center.